इसलिए उन्होंने ये कहा कि the residents told him that the patient is unwilling to get an ascitic tap. तो पेशेंट ने पूछा कि आपको किस तरह पता है कि मेरे पेट में पानी? उसने कहा उन्होंने कहा कि ये देखें आपका पेट कितना फूला हुआ है. तो पेशेंट कहता है इतना तो आपका भी पेट फूला हुआ है.
We were faced in a similar situation. So my consultant, he told them the taste of the pudding is in its eating. I'm going to put in a needle and I'll demonstrate it to you that the water is there.
Yes, yes. So there are many ways to skin a cat. लेकिन just to come back to your question, अगर आपकी कोई साइन नेसेसरी है और पेनफुल है तो आप पेशेंट को पहले एक्सप्लेन कर दें और एलिसिट करें. अगर कोई साइन अननेसेसरी है, the examiner will not allow you to do it and cause pain. That's simple.
Sorry, sir, just to complete this.
Yes, yes.
I think in this country of ours, I think we should be able to do a non-touch technique, that we can examine the hand while the patient is doing it for us. Flexion, arms, everything is almost done, apart from the thing that actually should be touched.
Exactly. What we do, and when I teach trainees rheumatology exam, I say, first inspect, you observe the movement, range of movement, and then you go to that area and examine. So the palpation has to come after the inspection. If the patient is able to do everything, and he said कोई shoulder में pain नहीं है, you don't need to spend time and do that. So you focus your attention in areas that require palpation and range of movement. Our tenderness has to be elicited in rheumatology on two counts. One is tenderness on palpation and the other is tenderness on movement, as opposed to abdomen or chest जिसके अंदर हम movement से नहीं relate करते, we are just relating to pressure. Please.
Now we move to the spine. With the patient standing, inspect the patient from behind for evidence of scoliosis and from the side for abnormal lordosis and kyphosis. Now the scoliosis may be true or it may be functional. Like if the patient has a limb length discrepancy, then it might be because of that, and if the patient sits, then the scoliosis is corrected. Or it might be due to some spinal problem like tubercular spine or fracture or anything. Or from the side for the lordosis and kyphosis, same fits with the kyphosis. Like it may be functional if the patient is having any chest abnormality or abdominal pain or pancreatitis, something like that. Or it may be due to Pott's disease or spinal the vertebral fractures. Ask the patient to tilt their head to each side, bringing their ears towards the shoulder, assessing lateral flexion of the neck, and bend and touch the toes. So if we ask the patient to touch his ears to the shoulder, this will assess the movement at the cervical spine, and laterally rotate like हम कहते हैं सलाम फेरे, so that the lateral movement of the C-spine. Ask the patient to bend and touch their toes. Assess lumbar spine flexion by placing two or three fingers on the lumbar vertebra, as we know that the skin stretches when the spine is flexed. Your fingers should move apart on flexion and back together on extension.
Okay, I'd like to take this opportunity to demonstrate this. Now, if I'm unable to touch my toes, the possibility is that my hips are bad, or my spine is bad, or both are at fault. So the reason that we have to separate the spine from the hip is because we want to determine whether this is hip joint disease or spinal disease.
If you're not able to touch your toes, how does the hip come in?
When I flex, when I flex,
Flex
this is
karna.
the pelvis, right?
Right.
I will bend at the spine and bend at the hip.
Right.
So the hip joint is over here, right? For example, look at me. I have a very straight spine now, and I can choose to bend at a straight spine. This movement is happening at the hips, right? Or I can fix my hip and try and bend at the spine, right? So therefore, you want to separate that, right? So we talked about the Schober's test in